second thing to let you know, I have put this information in the chat, but if you cannot see it, just a reminder, please, if you are not speaking, please keep yourself on mute to allow the presenters to speak and be heard clearly. And we will hopefully have time for chat, and we will also pick questions up from the chat. So if you want to put your questions into the chat box or observations, please do that as we go along. The next thing to remind you, or to let you know rather, is that we are going to try and capture some information. Andy will explain in a little more detail, but today's session about the impact of the response to COVID-19 on the uptake of digital health and wellbeing tools and services is part 1 of 2, and we plan a second part in September. So in order to help us plan that second part and to gather information more about what you want from this ecosystem, we have put some questions into Mentimeter. If you go to menti.com on your phone, on a second screen, on another device, and you enter this code, you will come to this session and the 3 questions that we have put for you. The questions are very simple, and we hope you will engage with them. Okay, I'm not going to spend any time on these because you will see them on the Mentimeter. And I'm going to stop sharing that and share Andy's slides and hand over, hopefully.
That's just a flyer.
Oh, sorry, Andy.
Right, I'll send it. I'll flick mine up because I can got them at hand if necessary.
All right, you go ahead. I don't want to waste time.
Okay, so.
Sorry, Andy.
Apologies for that. Okay, I need to. If you stop sharing your screen, I'll just buzz mine straight on.
Yeah.
Thanks. Here we go. Okay. Okay. Good afternoon, everybody, and welcome. Thanks for that, Nessa. Just a quick introduction. I want to take up less time talking today and more time listening, because today is an important start for what's the first ecosystem in our thematic innovation ecosystems around digital health and well-being. As Nessa said today, we've got some great opportunities to feature examples from both Scotland and Slovenia, but also later to have a longer discussion between all of us who are here today in terms of where this thematic innovation ecosystem goes to in terms of its future. Just before we kick off on that, a little bit of background for you, so you're all aware. My name's Andy Bleeden. I work for the European Connected Health Alliance. I'm the director here for our ecosystems and our membership. We're a member organisation. We have about 800 odd members, most of which are public bodies, not-for-profits, all in health, dotted all over the globe. And we use our ecosystems typically to bring those people together, start connecting the dots and make meaningful action happen around some of our health priorities. And never has there been more relevant time to do that than during the pandemic. People join us for the reasons you can see in front of us, but I'm not here to talk about membership of the European Connected Health Alliance today, because that's something we can do in another session. But today's focus is going to be more on our ecosystems and the way we use those to bring together all of those stakeholders that are there in health and social care together, bringing them together in a way that they can start to break down some of the silos in healthcare that are still there from the days I started working in health and social care in 1990, to also actually do something, to actually make some transformational changes in healthcare, because that's what we're keen to do. By doing that, we think, because of the way we spend so much money on health and social care, that's the way we can create economic opportunity. So we bring all the stakeholders involved in health together, but patients are at the centre all the time, leading with a need. We've built that network up now internationally to go all over the globe, from Argentina to Canada, from all through Europe, over to Australia, and including it now India, and moving into Africa as well, because people get the idea and the concept of ecosystems. But because of the pandemic, what we've done in the meantime is to start to see more areas where people want to collaborate together and listen to our ecosystems, and especially listen to colleagues from Scotland. We've started to build and develop and deliver a series of what we call thematic innovation ecosystems, which will be targeting the 7 areas you can see in front of you today. We've already had a couple kick off already on skills for health and on integrated care earlier on this week. But we're proud this week to also be looking at the area of digital health and wellbeing and targeting on what we sort of think have been some of the great changes that we've seen within the pandemic from two countries today. Scotland, we're going to be hearing from both Morag and Margaret, but also from Gregor from Slovenia as well. What we'll also be doing is then afterwards coming back to you for your ideas and your comments and your feedback. So enough talking and definitely enough slides for me. And I'm going to hand back to our next speaker.
Thank you, Andy. And just while I flip back, our next speaker is our boss, Margaret Whoriskey. Margaret is the Head of Technology Enabled Care and Digital Healthcare Innovation at Scottish Government. Hopefully you can see the slides, Margaret, if you let me know when you want to go ahead.
Yeah, thanks, Nessa, and good afternoon, everybody. I'm delighted to be able to contribute and participate in this session. I think the importance of the ecosystems and knowledge exchange, is really relevant, particularly where we are now and where we need to go. So just by way of a little bit of context, you can put up the next slide, Nessa. I'm responsible for the Scottish National Technology Enabled Care Programme, which has been in place since 2015, building on some earlier work that was already underway. And the aim is really to facilitate the shift in health and care systems from crisis care to more preventative supported self-management enablement by looking at opportunities for digital and technology approaches. Clearly, the last year has seen a huge take-up in digital services and building on work already underway, but many of these were at a fairly early stage of adoption. And we have seen, as I say, significant expansion. And I want to reflect a little bit on, why that may be the case. Next slide, Nessa. So in terms of, I suppose, the approach, and I think this is important in terms of creating the conditions for how we then support scale up and deployment. So creating the conditions as part of a national programme where we provided some dedicated funding, national support, local engagement to facilitate that scale up and transition to mainstream. The programme is very much positioned as a cross-sector leadership collaboration. So working across health, care, housing, our third sector partners, independent care partners, and others. So that's a really important cornerstone of the approach. In Scotland, we have a saying, once for Scotland, and that's where we can, if we can do something once for Scotland and it works, we want to be able to facilitate how that can be applied in other areas. But we can also do things once for Scotland at a national level that can help then local adoption and delivery. And the fourth point there is really about working together and building in some of the expertise and learning from not just the experts in the subject matter, but really the experts who are delivering services on the ground and our citizens, clearly in terms of their experience about how we build that capability. Next slide. So I'm going to show you just 4 examples, and Morag and Scott will talk a bit more around the remote health pathways work. So the first visual here is our Near Me video consulting program. So in March 2020, we had about 300 consults a month. We had a national program to try and engage with all our health systems around how they could use Near Me, but clearly the pandemic struck a huge disruption, and we saw our weekly calls going from 300 a week to 20,000 a week, and we're about to hit our 1 million appointments in the next few days. So that's a very significant acceleration. The dip you see there is to do with the Christmas and New Year break, where a lot of routine services were paused. The second example is our mental health services. So again, we had a digital mental health program underway for some time, but again, huge acceleration over the past year, both in relation to the range of referrals and also the range of programs now available. And there's 1 in 4 referrals now for psychological services in Scotland are for digital mental health services. So that's, again, a huge shift. The bottom one, the first one there, is around our Scale Up Hypertension program, which had started well before COVID, but again has continued, and Maura may pick this up in her talk. And we have over 50% now of GP practices in Scotland using remote monitoring to support diagnosis and management. And the fourth one is a really important one, because this is the message about digital inclusion. The example here is around care home residents, a very vulnerable group, and particularly vulnerable during the pandemic. And we have been working with our national programme Connecting Scotland to enable residents in care homes to be digitally enabled. And that's been about providing devices, support, data packages where relevant, working with the staff. And about 91% of residents in Scotland now are covered by this programme. Next slide, please. So in terms of what's some of the learning about our ability to have done some of that rapid scale up and incorporate new programs such as our care home program and digital inclusion, well, we've had good policy, and we've around technology enabled care and digital health and care, and also very clear government commitments that have become more apparent in the last week with our incoming government elected just over a week or so ago, making very clear commitments around digital access and services. But also the programme that I referred to earlier has been a really important linchpin of creating the conditions, working on earlier pipelines, providing funding, early tests of change, supporting early adopters, doing that national work that can really facilitate local access, and developing those Once for Scotland programmes that just were before the pandemic, but again, being able to accelerate those at real pace. Wrapped around some improvement support and change management, and importantly, drawing out that evaluation, that iterative evaluation, to be able to inform our next steps. Next slide, Nessa. And very quickly, in terms of going forward, we've learned a huge amount from COVID as well as our early experience. So we framed our delivery plan going forward against these 4 key strategic priorities. I won't go into all of those, but underneath those, there's a set of key programs and deliverables for the next year, but also trying to set the direction of where we're trying to get to over the next sort of 3 to 5 years. So thank you all very much.
Thank you very much, Margaret. And I'm just going to bring up the slides for our next presenter. Bear with me, folks. Sorry, Gregor. It's taking just a slight moment. I think my system may be zoomed out from this week. Right.
If you wish, I can share as well.
They're right in front of me, Gregor. It's just being a bit slow. Can you see that?
Yeah, I can see.
Wonderful.
Thank you. I'll just put it in full screen. Thank you. Thanks for bearing with me. Sorry about that, Gregor.
Wonderful.
Okay. Gregor?
Thank you very much. First of all, I'd like to make a connection between Scotland and Slovenia. There is a burning Prešeren society that cherishes the poets, the 2 great poets of these countries. Another one is that you have haggis, and we have something very similar. And the third one, I would like to mention that whatever Scotland did, I got infected by it when you guys first came to Slovenia in 2015, I think. And Andy was also in that group, so before we worked together. So that's sort of my intro. Now Slovenia, you know. So what is the implication of COVID-19 and how we work? First, a little bit about us. So of course we're an ecosystem, a full-bred ecosystem within the ECH Alliance network. We work within the technology park of Ljubljana, but we have been established from the side of the industry first. So I used to work for Better, which some of you guys know from other activities, because Better is a strategic partner of ECH Alliance. So it was more on the industry side. What ECH Alliance taught us was that the multi-stakeholder approach is important. So it's you have to involve patients. Let me start with patients, and then the academia, policymakers, investors, and everybody else. We talk about this very often. I think I can be really proud about the vibrancy and dynamics of the ecosystem. Also, relevance is growing from year to year. So currently, we are really strongly involved. Also, with the ministry now, we haven't done that before. But I think you can imagine, our program is really full. But if I just put it in three main columns or pillars, one is this communication aspect, having newsletter events, etc. The other one is support for companies. The third one is dialogue with the regulators. So somebody who needs to talk to the medicines agencies, to the ministry, to the health insurance fund, and so on. Next slide, please. So what was the COVID-19 response in Slovenia? So we've had two levels of response, and I will start with the informal one. Sledilnik would roughly translate to tracker for COVID-19, but if you want to Google it, you will find it under Sledilnik. And it's an amazing endeavor that started. Diane, you said you can't see the slides. Are the slides visible right now, or is it from before? I'm sorry.
They're visible.
They're visible. Thanks.
Visible to me.
So what is amazing there is that it was a really grassroots initiative without funding, still without funding after a year, and they don't consider it a problem at all. It's just a cooperation between people of interest who came together already in March last year to start basically doing better analysis of data than the official institutions. And there is a sort of a passive-aggressive approach from the institutions towards Sledilnik, because Sledilnik is actually pushing the envelope. It's one of the best quantitative approaches to COVID-19 globally, actually. And it's really amazing at how it works. You can check them. You can check them out on Google. But the story is still, the way they are working, I mean, is really something that we need to understand and study. So Helde is in a very good relationship with them, but the government in a way is not. So this is different from the Scottish government, I would say, who are one of the key drivers of your ecosystems, obviously, and we are at your webinar today. Informal also ventilator production. What came together was the development heads of different technical departments of top companies came together to develop our own Slovenian ventilators. Even 3 groups came together. Suddenly in March and April last year, nobody had these IP problems or problems of allocating resources, etc. So that was really incredible to see. Cell therapy treatment of ARDS, successful cases of really novel therapies coming ahead. Full disclosure, I'm involved with a company that does that. Formally, teleconsultation never was on the list of the health insurance fund, so we have one main state fund, but it came on the list for the GPs in April, and then for other specializations in 2020. There is a lack of understanding still today. I will talk about this in the next slide. Lack of understanding that telemedicine is not just teleconsultations, but much more. So, of course, we've had the obvious things, that we're following. So we have nationally deployed testing, we have nationally deployed vaccination, and everybody is sort of, let me say, gaga about RRF, because there is about 80 million funding for a 2 million people country. This is quite a lot. Also, I would say that digital health is super underpaid in our system. So we spend about 1% of the total healthcare budget on informatics, whereas the European average is about 3%. Next slide, please. So what are the lessons? The biggest takeout and the biggest, the change that made this big how do you call it, the glacier? Healthcare is like a glacier that doesn't move anywhere. It's frozen. So one of the metaphors is that we're actually trying to introduce innovation is like trying to melt a glacier. It's perhaps not the best metaphor in these times when we don't want the glaciers to get melted. But what happened with COVID was that the biggest changes that need to happen actually start happening in the minds, in the heads. and doctors changed incredibly. I mean, this change of attitude of doctors towards digital health is immense. So just that change alone is sort of a harbinger of, you know, everything that is coming. So I saw a piece of data, piece of research saying that before COVID-19, like 10% of doctors considered digital tools to be of any relevance to their business. And then it grew in the summer already last year to 70%. We are lacking a digital health strategy, but there is a tender out for the preparation thereof. Telemedicine is more than teleconsultation. I like to compare telemedicine to how it should be to comparison between a Nokia feature phone to an iPhone. I think you quickly understand, you know, that we're talking about much more than just trying to replicate what we see in the classical world. And telemedicine is just one comparison is, instead of going to the doctor 4 times a year, your data is with the doctor 365 days per year. That's, you know, that tells the whole story in a way. And also one thing that is really important, digital transformation is not about informatics. It's just, you know, enabled by informatics, but it's truly about reorganization, about change of, it starts with a change of mind, but we've got it here. So the moment is right, but it needs to go towards, you know, changing of the whole system. It's not about the 1% that we're spending or perhaps increase it to 2 or 3%. It's about how Slovenia will spend the 4 billion that we spent on healthcare. This means about 9% of GDP, so I would say we're average or a little bit below average, I would say, but definitely not at the 18% that the US spends or something like that. There are many new types of initiatives that are emerging. One of them is Sledilnik that I mentioned before, but we are seeing new types of collaboration, and this is where ecosystems become crucial. Because ecosystems are in a way networks of trust, and you know, innovation really moves at the speed of trust. Next slide, please. So this is my final slide. It's not translated there, but there is a sort of a illustration that tells the story of the vision of where we want to move. So we see that it's a long-term project. So it's like building of a house, and it's a very complex house. And actually, we can't tear down the old house. You know, we have to renovate it. You know. But the bottom, you know, in the green field, you will see that it actually says digital literacy, or also the attitude, the digital skills and stuff like that. I think you understand the digital infrastructure part. And then you will find in the house, you will find everything from AI to personalized medicine to robotics and stuff like that. And outside, you will find cybersecurity and insurance and payments and the legislation. But we feel that one of the lessons of this house is that we used it as we created this, you know, because we wanted to tell to the doctors, you know, how digital transformation will affect them. And what I personally found out is that I really don't understand doctors, and I think most of us who come from the rather more informatics side. We are wrong about understanding the doctors. We actually don't, and trying to understand them is very hard. So we really need to work with them, and their view of the world, especially about informatics, is completely different from ours. Thank you very much.
Thank you very much, Gregor. Really interesting presentation. I'm not going to go into comments and questions. I'm going to go straight on. So hopefully we'll get our next presentation up, folks. I'll just take this point to remind you also to use the Menti, if you could, when you get a moment, if you're thinking about those questions. Sharon will put the link and the code into the chat again, so you can see it. And we'll go straight on. Now we have an example really about service scale up from a specific service in Scotland. If you can let me know if you can see these slides, okay, please.
Yeah.
Okay.
So, yes.
So I'm handing over to Maura Carty and Scott Henderson, who is going first.
I'm going first, Nessa. So good afternoon, everyone. In this presentation, my colleague Morgan and I will share our experience of responding to COVID-19 from the very specific perspective of remote health pathways, and we'll quite briefly cover what is meant by remote health pathways, how COVID-19 changed our strategic approach, what that has meant for the way we work now, and how we're extending digital services into the recovery phase. Next slide, please, Nessa. So in terms of what remote pathways actually are, it's a term that we use to describe the use of digital technologies to enable citizens to gather, send, receive, record and relay relevant information about their current health and well-being as part of an accepted healthcare pathway. Typically, but not exclusively, these activities are performed between citizens and clinicians while the citizen is located outside of traditional healthcare settings. This includes at work or at study, in their home or in a home-like setting. Remote health pathways are also a vehicle to support the movement of care delivery from acute settings back into the community, and they're used to support asynchronous consultation with clinicians to guide both supported and independent self-management decisions by the citizen, and to support health and care teams in their diagnosis, treatment and care planning activities. Next slide, please. So to put things in context for this work, I guess prior to COVID, the tech program had a dedicated work stream that was supporting the adoption, spread and scale of what we called home and mobile health monitoring. And for the range of activities that this involved, the main investment in time and resources was in three areas. Firstly, a program that Margaret touched on very briefly and showed some performance slides on earlier, is a program called Scale Up BP, which is a hypertension diagnosis, titration and long-term monitoring program in primary care. The second focus was on a procurement exercise to upgrade our remote monitoring technologies from SMS text to a multi-channel approach. And thirdly, there's been significant investment in time and effort in developing a community of practice and emerging a pipeline of new remote services. Next slide, please. So with classification of COVID-19 as a pandemic a year ago last March, this triggered national emergency response mechanisms. For Scotland, that meant gold, silver and bronze command structures, very much command and control. And along with this came a significantly increased profile for a wide range of digital activities. And all of these came to the fore very, very quickly. And the category of remote health pathways was formed to coordinate the work around related projects and programs that could support the immediate COVID response and support service recovery and mobilization. Next slide, please. So this much wider remit has promoted and supported a range of new and very productive collaborations, both across government and with our delivery partners. The circumstances have also enabled the development and adoption of initiatives at a very much faster pace than before. And I think this, plays into what Gregor was saying earlier. You need to have these collaborations, and also the change in mindset, particularly from our clinical colleagues, about being positive about digital rather than being suspicious of it, has been a huge factor. So we want to preserve the best elements from these as we move into the next phase, and Morag will now share the work that these collaborations have produced for us.
Thank you. Next slide, Nessa, and good afternoon, everyone. So just to let you know that our engagement with the territorial health boards in Scotland and the others Scott has just spoken about collaborating with confirmed the priority pathways we would focus on and provided us with a roadmap for the response and the recovery using our new emergency procured solution at that time. As you might expect, there was no great surprises here, and it should be noted that here you might wonder diabetes was not included, and that was due to other dedicated national work already underway. This was to put pathways onto our new procurement, I have to emphasise. The Scale Up Blood Pressure programme Margaret and Scott have already spoken about was there, but we were revising, and we are revising this pathway on the new procurement, which is giving us those multi-device options. So it was on an SMS system. And we'll want to transition that. Next slide, thank you. to underpin all this, we needed a national process to be developed with the steps, gateways, clinical approval, and then supported with our supplier who helped us build the pathways. These were step changes there. It was a fairly linear process, however, it didn't transpire like that. And this was all underpinned by the strategic priorities that Margaret has already spoken about, redesigning services and innovation. So these really fed into all of that. Thank you, Nessa. Of course, this process was only the tip of the iceberg with regard to the actual work involved, as Scott's already alluded to. The next two slides really just give a flavour of this widespread engagement, training, project support, escalating the clinical approvals and the guidance and development that all went into the mix here. You know, we had a great deal of help right across the board with all of those groups, but we kept uncovering something else we had to take into consideration. We weren't without experience, but certainly we were trying to do this, as Scott has already said, at speed and scale very quickly. Next, thank you. So testing, training, we finally got to that red letter day when the first patient was onboarded with our COVID-19 pathway, which was our greatest challenge and responsibility to get up and running as quickly as we could, as you may understand. We navigated the information governance and the clinical safety reviews, with record integration. We wanted to be able to have the information being fed back into clinical systems. And of course, don't forget our local boards and the patients that we needed to test and to feed back to us and keep us right. And we went round about the whole nation, explaining this, collecting feedback, and of course we've got our early evaluation has already started. Thanks, Nessa. This is our COVID-19 monitoring pathway. This was, you know, the lessons learned along the way. They certainly informed our process for the other pathways. And it wasn't always that straightforward linear process, but simultaneous progression is absolutely essential. This slide gives you an overview of our COVID-19 pathway patient information. So it shows you there that we do have 3 options. It wasn't just an online or an app. We had text messaging or an automated phone call, because we do still have some areas where cloud server and mobile providers are not really as reliable as we would wish. And interestingly, I'll just say one thing on this one. For this particular cohort of patients for the COVID-19, remembering it was a different cohort from what we might have been used to before, they actually, the majority selected the text messaging system, which was a surprise to us because most people are starting to move to online and mobile apps. But remember, this was a 14-day pathway they were on. They weren't well, they were under a great deal of emotional and clinical and physical pressures at the time. And that's really where we got with this one. The whole idea was that we would give them pulse oximeters and they would submit their clinical readings and their symptoms, triggering automated advice, information back to the patient. And the whole aim of this was to identify an early warning of a worsening condition. So not so much keeping people out of hospital, but actually making sure they were able to have a response to something becoming worse that was not always evident from their symptoms themselves. They needed that worsening oxygen level. And the early evaluation of this is showing very positive outcomes with early indications and patient feedback, which is always most important, saying it provided them with a really good system. Thanks, Nessa. Just a quick word, Scott has already spoken about that remote health pathways monitoring procurement that's underway. And we've identified the need for a single supplier who could provide a highly adaptable and accessible product with the ability to connect to other systems. As Scott says, we're expecting a final completion this summer, so we're well underway. And the experience of our emergency interim procurement that's been working on has been invaluable to the final stages in this new procurement. It really gave us information that without the last year and so on, with a new procurement, we would not have been in a position, we wouldn't have been nearly as confident in some of the information that required, and we wanted to obtain from a new supplier. So next slide, thank you, Nessa. And just finally, we've given you a very whistle-stop tour of our programme, and what we expected to be a fairly straightforward journey has proved to be anything but. However, as I've said before, full credit must go to our project teams. We really ramped up our project support. We had support from our other organisations within Scotland, our National Services Scotland and our education services, and our local teams and the partners who supported us on this journey throughout and were with us and continue to support us. So thank you very much. And just final slide is just any questions, clearly, obviously, Nessa, thank you.
Thanks, Morag. Thank you, Scott. Thank you, Gregor. Thank you, Andy. Everybody gets thank you. We have a little bit of time that we can take a question, I think, Andy, a question or two from if any of our attendees would like to ask a question. I'm not seeing any in the chat right now, so let me just stop sharing so I can see where we are. And Sharon has also, and Andy has added the Mentimeter link and the code if people want to also have a look at that if you haven't had a chance to. So I'm going to ask people if they wish to put on their screens, they can do so. They don't have to. It's not compulsory, but I will put on my screen so you can see me too. And we have Mamie joining us and Diane. Hi, folks. So does anybody have a question? Let's have a couple of minutes of questions for our speakers.
I'll ask something, Nessa. It's Leo here again.
Thank you, Leo.
Yeah, and I put it in the Mentimeter response as well. I think in my own experience, both in Wales and in terms of what I've learned from other places, yes, we saw a great shift during the real crisis period of COVID, but we're also starting to see many of the care team members reverting back to normal practice. Part of the reason, I think, is that because it was sort of firing from the hip response that most regions had to do, that the actual consultation redesign has yet to be done. And that to me still feels like a bit of a gap. And it's where we really need to be focusing, you know, particularly in primary care with practice nurses and GPs, for example. You know, they are reverting to telephone rather than video a lot of the time because video, they claim, doesn't suit them, etc., etc. But I also have an interesting observation on it all, because I think if we reflect back to the situation prior to COVID, for most of us as people, we didn't have any choice as to how we consulted with our care team. It was in person. Digital has given us that choice. And because of that, we need to ensure that the choice is maintained. It's not digital first or nothing. It's about people being able to choose which mode they would like to consult and get support from their care team members with at different points, because we all know that for different conditions, we may seek a different mode of consultation. And that's quite an important distinction, I think, that we forget about, because we're very good at highlighting the digital divide, but actually, if we reflect on the situation before COVID, you know, you either had face-to-face, and if you weren't able to go for a face-to-face appointment, it was tough shit. You suffered, basically, or it was inconvenient and other people suffered, or you took time off work. So you may have suffered financially. Your colleagues may have suffered as a result of you having a problem that you had to go for a face-to-face appointment for, etc., etc.
Sorry, I was on mute. Thank you, Leo. And actually, I think in one way that, you know, that's the value, hopefully, of these knowledge exchange ecosystems, is that who is making that shift in service delivery and the models of care, as you mentioned, and the pathways, as Morag has described with Scott. You know, who's doing that and how did they do that and did it work? So I'm just asking again if there are any specific questions for the speakers before we go and have a look at the Menti questions and responses.
Nessa, could I just sort of respond a little bit to what Leo said? I think it's a really important point. And I guess we've seen some stability in, say, like our video consults, you know, so it went up to a maximum of 22,000 a week. It sort of dropped a little bit. So it's hovering around the 20,000 a week now for some time. And that's across primary and secondary care. So I do think there's something about how we continue to support our delivery partners in terms of how they integrate, you know, some of the technologies that have particularly been deployed in response to COVID. And I think the other thing is, which again, Scott and Morag referred to it, is where we're trying to not keep things in a digital or tech space. So it's about working with the other big priorities. So, you know, scheduled care, trying to get sort of elective appointments back up and running has been a huge priority of Scottish Government, as well as urgent care and increasingly social care. So I guess what we're sort of trying to do is really work hand in glove with these other programs, so that we try and enable that digital as an enabler gets embedded, as opposed to sitting as part of just a digital program. So I think we've seen some progress in that regard with the remote health pathways work that's been described, where COVID brought us much closer together. So I think we need to do much more of that in terms of trying to integrate it. And I think the example you've given about GPs is, yes, I mean, I think in Scotland as well, you know, all appointments start off with a telephone consult, and then they decide whether they see somebody face to face. There are some GPs who are using video consults a lot more than others. And I think, again, we're trying to do some work to maybe identify, you know, what type of appointments and how do you make it easy for the GP to switch from a telephone into a video call? Because if they have to, you know, hang up and re-log in and everything else, you know, I think that's, so there's some aspects of the technology and the way it works that I think could improve that seamless way.
Thank you, Margaret. Thanks very much. And for those of you who weren't on, we had an earlier session and Leo was on, and Leo was giving, actually, Margaret, on that point, really nice example, I think, Leo, about trying to focus on self-management, and then where does the technology fit into that, particularly post-COVID, remobilizing services and waiting times as a particular challenge. So I'm going to ask Sharon, if Sharon can screen share so we can have a look at our Menti questions and responses. So the whole purpose of this innovation ecosystem and this session, as I said at the beginning, and just for anyone lately joining, we are doing kind of two parts really today. First part is, yes, we know there has been a significant scale up of digital health and care or digitally enabled services. But part two, we want to move the focus and the conversation onto how do we make that change stick if we do? And can we demonstrate examples from the European Connected Health Alliance and new members, new regions? Can we demonstrate examples of where that shift is actually evident in policy and strategy, not just active projects and good work, but really shifting? So the first question we asked everybody today, thank you, Sharon, is the shift to digital really changing health and social care service delivery? And for us in Scotland, of course, it's health and social care, it should be. And we had yes from 12 people. We've got 21 folk on just now. So maybe a couple of the speakers, obviously, when you were speaking, you didn't get a chance to contribute. And that doesn't surprise me. Andy, anybody else like to come in?
No, I think that's completely unsurprising. I wonder if the question would be the same if we asked our patients and citizens. Yeah, no, very fair point. And that's a whole part of the conversation. Obviously, we're not really able to address here today. Yeah, no, good point. Sharon, can you go on to the next one, please?
And so hopefully this is where we hopefully find our examples to feed into the session in September, but also to share with everybody who wants to know how this stuff is developing. So do you have examples of where the change has been embedded in policy or strategy in your region, and include which region? So I won't just read out the ones from Scotland. Not dissimilar to Scotland, solutions to support remote consultations. Slovenia is now being prepared, will take some time. Digital citizen pathway. Okay, in Hessen in Germany, new project, nice project, sorry. Gesundheit im Quartier, I can't pronounce that terribly well, apologies to Hessen. Just ending, a follow-up has started. Okay, that nice link, thank you, thanks for sharing that. We may be coming back to you very soon. I'm just looking at the chat simultaneously. So Morag has made the point, and this relates really to the first question about the shift to digital, that a choice is vital for citizens, and remote working, remote monitoring, I beg your pardon, supports effective conversation taking place, whatever the communication channel is, wherever needed and face-to-face. It enables citizens to take control, of course. And Mamie just agreeing with Morag. Exactly. So would anyone like to comment rather than just hearing my voice? Thoughts on this? Morag? Are you surprised by the responses, Morag, or are you feeling kind of heartened by them?
I'm not at all surprised, and I think we've all seen a shift. I think it was completely right that I think we will see a bit of a downturn. My own thought, and it's a relatively personal thought really, is that for some it's a bit like going back to pubs and restaurants and things. It's a bit of a novelty. We haven't done it for over a year, so let's go back and see our clinician face to face, and then realise, why am I bothering? I would just be as easy to do it another way. So I think we might see another upturn once people settle down into what is the new norm. Because people have got used to all sorts of other things they're doing by digital means. So yeah, I'm cup half full here. Thank you. Good.
That's what we like to hear. Andy, were you laughing at Morag's point, or were you?
The big test is can you remember the last time you went to the doctor and they had a cold? And would you feel the same next time?
Yeah, exactly. I would agree.
Okay. Scott, can you come?
Yeah, I mean, I think not at all surprised by the response. I guess there's a further question, that things have changed, and how do we make sure that the change is for the good rather than just a change for the change, or a change for the worse even. I mean, we kind of make the assumption that because we all love this work, that any change that we make with it is for the benefit, and it's a good thing. And I think we have to sometimes caution ourselves a little bit that we need to make sure that it's actually making an improvement and making a positive difference. And I guess the other component here, I think, is cultural as well. So Andy mentioned, when's the last time that you visited as a GP and they had a cold? I actually did have a face-to-face visit with my local GP in recent weeks, and the conversation that we had strayed into beyond what I was there to visit the GP for, because she wanted to know what I did. And very interesting conversation then ensued about, oh, well, I got into medicine because I wanted to interact with people. And doing everything remotely has been really, really difficult for this particular GP, and is actually looking forward to being able to interact with their patients. And I think that's something we need to be mindful of, that yes, digital first is a great idea in as a thought, but in practice, there's a blended model here. And I think if we do continually remind ourselves that this is about choice for the citizen, and maybe there's a bit of choice here for our professionals as well, that collaboratively we can get to a place that's much better than where we are now, certainly a lot better than where we were 12, 18 months ago.
No, very good point, Scott. Sorry, I was on mute there. Sharon, I just wondered, can you scroll down a bit, or is that maybe the end of the screen? Yeah, it's just all right. Okay, that's fine. And the final question, can we see it? So while you have a look at that, we also have a comment in the chat, and it's actually from Diane. Sorry, I have to look to the other screen for a second to get that. And I wanted to put it to Margaret, if I can find it again. Okay, Margaret, any of the speakers could answer really, but I would like to bring you in on this, Margaret, and perhaps Gregor as well after Margaret. What are the speakers' thoughts about key strategies? So Diane, I'm assuming, I don't want to speak for you, but you're meaning really specific strategies that could be implemented to help build resilience around digital transformation. Yep. Margaret first.
Well, I think as I was saying in my earlier sort of comment, I mean, I think it's about how we have a clear authoritative direction around digital health and care and what needs to be put in place to facilitate that adoption. But it's also about the strategies that are being developed across a number of areas in health and social care and how we embed digital in those. So for me, it's breadth in terms of trying to ensure digital has a footprint in the work that non-digital people are doing and setting out, but also that we have real clarity, I think, in terms of what we're doing, what we need to do by when. And that focuses on the digital foundations and infrastructure that's required to be in place, including connectivity, digital services, and that sort of digital leadership and skills, that we need to be looking at it from a workforce perspective as well.
Absolutely. Thank you.
Thanks, Margaret. And Diane had made an additional point about should we be looking at integrated digital, which really picks up on that. And I think actually goes back to what you were saying at the beginning in your presentation about, I was struck by the amount of dialogue that you'd had and the different bits of the sector that you were very clearly, as we have in Scotland, bringing together, whether they were suppliers or whether they were politicians. Would you like to pick up on that?
Yes, I would like to. I would like to emphasize that there is in this multi-stakeholder dialogue there is typically a missing part. I can't judge for anybody, so I'm not sort of blaming any of the ecosystems, not at all the Scottish one, but a typical lack that we see is something that stems from European projects typically, and it's not the fault of the European project. It can be, I don't know, a national project, etc. So the projects are skewed towards creating papers. Fantastic reports, but the real life traction is low in most cases. I just remember a recent discussion I had with one of the most advanced ecosystems in Europe. I do consider Scotland to be one of them, but it's a different one. And I don't want to name them because I don't want the blame to be sort of scattered around. But they said, we have a strategy, but we lack an action plan. Sorry, guys. I mean, do you have a strategy? They say, yes, we have. But, real life starts when, there is a phrase in English that I will probably say wrong, as I'm not a native speaker, which is, when the rubber meets the ground, something like that, that's where things happen. So don't create just paper strategies, make them relevant for the people. What happened to Scotland, I like to tell to many ecosystems, including ours. So it's a learning lesson. You basically took your teleconsultation infrastructure and scaled it up 100 times, which is like the Margaret showed the first slide, on the slide where she had 4. Basically, you had 1,000 telemedical discussions in February last year. Whereas in October, just in 1 week, you had 18,000. I remember the data because I used it in a publication I made in March this year. Thank you very much, because it helped. The whole point is, unless we go to the millions of citizens that we represent, then we're creating, paper castles. I'm sorry to be critical because it's a critic that goes to ourselves as well.
Thank you, Gregor. And Donna has made, Donna, rather than me read it all out, would you like to come in and just make your point?
Just trying to find my unmute button. Yeah, that's a real shame, Gregor. I think that's been your experience of EU-funded projects, because I think certainly from the Scottish perspective, and Morag, for one, on this call, has certainly been involved in one of the largest EU projects that we were involved in, United for Health. But our experience of European projects in digital health and care, without doubt, they've actually helped shape the current agenda. So we can see that our digital mental health agenda has been shaped by Mastermind and the project that we were involved in there. The work that Morag and Scott are doing have been very much shaped in the early days by the work from United for Health. Very challenging projects, there's no doubt. They weren't easy, and they were very difficult, but the learning without doubt is evident if we look back on the audit trail, you know, of kind of developments in Scotland. So I think it's a real shame, actually, and I think I just wanted to offer a counter view on the value of EU funded projects.
Can I just come back on that, what you just said? United for Health is one of the prime examples of creating a great project. It was Slovenia was involved, a region there. So we created something that had a real impact on 500 patients. That never scaled. So that project was starved almost to death. It survived, but on zero budget. So simply goodwill of the hospital. What I would ask Scottish government to do, honestly, and it's not, you know, it's no reserves here, is to help us, especially during the presidency, which I know sorry for the European agenda here, but anyhow, I think, you know, that there are some things where we could need your help, and I do appreciate what you just said, Donna. And I see that it's possible to do things differently.
Thanks, Gregor. I totally understand your point, and I think maybe we're a little bit luckier in the sense that we've been well connected to these projects at a government level. So we've been able to take those lessons and feed them back in at a policy level. I think if the projects are being undertaken, you know, maybe by different entities that are not so well connected to government, then it's much more challenging to shape policy. There's no doubt about that. And without shaping policy, then if you don't have that governmental backing behind you, it's very difficult to sustain these services beyond project and pilots. So yeah, I completely understand the challenge that you were describing, Gregor.
I'm just going to come back in as we move to close in a moment or two. The point from Leo in the chat about job plans needing to blend digital with face-to-face. I mean, that's another aspect of this. We've asked about your examples, clear examples of a transition and a recognition of digital in terms of policy and strategy, but workforce development is obviously the other chunk of that. So I'm going to hand over to Andy just to bring you back in, but just thank you everybody for contributions in the chat and discussion.
Thank you, Nessa. Thanks for the conversation. It's one of those rare occasions with webinars when we kind of think, oh, we could do with some more time, because it was just starting to get interest. Well, not that it wasn't interesting before, but it was starting to get interesting. Sorry, I put my foot in it again. But it's starting to get interesting, because that's where we need to start thinking of next. It's those issues like Gregor was saying, is how can people then scale up after projects. We've seen some suggested ideas in terms of next steps for this ecosystem. I'd like to be able to offer, firstly, my thanks for all the speakers. Secondly, I would like, if we'll be able to extract, he says, with all certainty, all the information from the Mentimeter screens that we've got, and share that with both attendees, people who couldn't attend, but also we've just literally stuck up the first web page for our thematic innovation ecosystems. This plus the recording plus the best practice and the presentations you've shared, I want to badge up there, and some of the topics, and get some sort of consensus from people around where we're going to go to. We've obviously got the part 2 of this, which is the policy discussion, but that, I think that the idea is that we've got some really good examples, both in the chat and in the Mentimeter there, for topics for the future. So anyone else who's got any input, I would like to formally thank Nessa for her hard work and perseverance for this, especially when naughty people like me send her the wrong slides, which doesn't help. But also thank our speakers from Scotland and Slovenia, some excellent input. I think this is where our thematic ecosystems work, by showing the best within our network. And I invite you to attend more of these in the future and get stuck in. I've put a link in the chat function for people who want to sign up as stakeholders in any of these. And I look forward to speaking to you all very shortly, very soon. So thanks Nessa, thanks Morag, thanks Margaret, thanks Scott, thanks Gregor. And again, thank you Nessa for your perseverance.
Joke now or not?
And no thank you for the joke.
No joke.
Thank you very much. Thank you.
Thanks everybody. Have a lovely
Bye-bye.
Friday.
Bye-bye.